Thank you. It's a great honor, and together with Eberhard, I'm happy to talk about understanding and preventing airborne transmission of COVID-19. So take a deep breath. Even if the air looks clear, it is nearly certain that you will inhale tens of millions of solid particles and liquid droplets. These ubiquitous bags of matter suspended in the air are known as aerosols. Aerosols in the atmosphere range in size from a few nanometers, less than the smallest virus, to several tens of micrometers, about the diameter of human hair. Except for different organic and inorganic particles, there are also many biological particles, such as virus, bacteria, spores, and pollens. Every one of us breathes about 11,000 liters air per day. So it is inevitable that particular matter suspended in the air is highly relevant for human health. Together with other air pollutants, it has been ranked as the top 5 leading health risks worldwide and showed strong influence on mortality over a vast area of the continents. In particular, human respiratory aerosols are involved in the transmission of SARS-CoV-2 and the spread of COVID-19. How to effectively protect people against the virus and end the pandemic has become the greatest concern of the whole world since the beginning of 2020. As we know, preventive and intervention measures can reduce the airborne virus load. But what really matters is if and how the reduced airborne virus load will influence the infection probability, both in individual and population average level. Early studies show that the infection probability and virus number are indeed linked, but with a nonlinear relation that can be explained by a single hit model. Here, I plot the curve illustrating such dependence. On x-axis, the virus number is divided by the median infectious dose, at which the probability of infection is 50%. For SARS-CoV-2, the median infectious dose is believed to be around a few hundreds to 1,000 viruses. And with this nonlinear curve, I will show that there are indeed distinct regimes of dependence of infection probability on changing virus number. In a virus-rich regime, when the virus number is much higher than the infectious dose, the infection risk is close to unity and not sensitive to the change of virus number. For example, in this case, wearing a mask may not prevent infection. However, in a virus-limited regime, where the virus number is close to or lower than the infectious dose, reducing virus number by taking measures become very effective in reducing the infectious risk. So whether the masks or other measures are effective in preventing the airborne transmission of SARS-CoV-2 depends on where we are on this curve. Here is an example how respiratory particles are emitted through activities like coughing and sneezing. Guess how many particles are there? 100 or 1,000? It is much more. According to our estimation, on average, there are about 3 million particles emitted by a patient in 30 minutes. But does the large number of respiratory particles mean a similarly large number of respiratory viruses suspended in the air? Don't worry, the answer is no. Based on ambient virus sampling data, our analysis show that if you stay for 30 minutes in indoor environment, such as Wuhan Fangcang Hospital or US and Singapore medical centers, you may inhale SARS-CoV-2 viruses from a few to a few thousand. It is actually quite little compared to the millions of respiratory particles emitted in 30 minutes. So not every respiratory particles has a virus in it. Now let's have a look how these data locate us on this curve. The left panel is with a low infectious dose of 100 virus, and the right panel is with a higher dose of 1,000. So we can see that most of the data falls into the virus-limited regime in these both cases, where taking measures like wearing masks can effectively help reducing the infection probability. Although these data represent nicely individual examples, to contain pandemic, we need a bigger picture. That is, on a population average level, what is the representative virus regime of COVID-19? For a population, the large variability of individual cases will change the shape of this curve. There are many factors that may lead to the variability, such as fraction of positive cases, the frequency of sneezing and coughing, how many and how long the contacts are, and so on. Among different factors, we find that the variability of virus load in the respiratory fluid is the most important driver. Here is an example of virus load distribution from 4,000 COVID positive samples. It shows that virus load from individuals can vary by 6 to 8 orders of magnitude. To approximate a population, we build on the infection curve from a single case and assume the virus number as log normal distributed with the width sigma in the range of 1 to 2, according to the distributions of virus load in the last slide. After considering the variability of the broad distribution of virus load, let's have a look how the infection risk curve looks like on a population average level. The black line is the original curve. The red and yellow line represent the population average infection probability with different degrees of individual variabilities. We can see that a broader virus load distribution with a larger sigma will lead to a higher average infection risk and a reduced sensitivity of infection risk to change of virus number. And this less sensitivity means a reduced efficacy of preventive and intervention measures. Now we have extended the infection curve from individual to a population average level. To locate the virus regime for COVID-19 on the new curve, we need to know the population average infection risk for the SARS-CoV-2. This may sound like a mission impossible because the available data on the left panel surely are far from enough to represent the whole population and numerous different conditions and environments. So instead of trying to collect more virus sample and measurement data, we adopted an alternative approach using the epidemiological data to estimate the population average infection risk. As we know, the basic reproduction number for SARS-CoV-2 is about 2 to 4, which can be related to a basic population average infection probability through this equation. With the average duration of infectiousness about 10 days and the average contact about 10 to 25 per day, we obtain a population average infection risk per contact in the range of about 0.8 to 4%, as marked by the shaded area here. This relatively low infection risk indicates a prevalence of virus-limited conditions where taking measures to reduce virus number would be very effective. In the end, I'd like to extend a bit on what this virus-limited conditions means for wearing masks in fighting COVID-19. Here, I give an example of surgical mask for source control, the red line, wearer protection, the yellow line, and universal masking, the blue line. An interesting feature of this curve is, even for the same mask with the same filtration rate, its effectiveness increases with decreasing virus abundance. This is very important because it implies synergetic effects of combining masks with other preventive and intervention measures that help to reduce the airborne virus concentrations. The more measures that are used, the more effective each measure is in containing the virus transmission. And we can see that for the ancestor strain with R0 of about 3, the universal masking of both surgical and FFP2 masks is very effective in reducing the infection risk. Even for Delta and other variants with higher transmissibility of R0 about 5 or so, the efficacy of surgical mask is reduced, but the FFP2 masks are still extremely effective. So with this, I'd like to close my talk, and I would like to thank my group members collaborators, funding resources, and my family. So thank you, and I will hand the stage to Eberhard. Thanks.